1, 2,
Patient here. Female.
Oh shit, almost got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's charter book.
300 please.
I'll keep your card again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what are the echo people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Okay.
Oh.
I wanted to get on here and I wanted to touch on something that I believe that most of us nursing students, if you are a nursing student, kind of feel frustrated about whenever you're in nursing school. And this kind of came up yesterday after we had a really rough exam in the mom baby section of our program. And so it is anticipatory stuff, not anticipatory guidance like in pediatrics, but just like the questions of the nurse will anticipate this or the nurse will anticipate that, so I want to kind of talk on that a little bit. So I'd like to kind of talk about that just a little bit. So um, it's a trauma story and it was a very interesting story. So um, in our particular trauma center, or emergency room trauma center, we have our ER kind of segmented into different sections. And so you will have a critical medicine side. You will have just a you're not dying medical side. And then we have a pediatric emergency center. And then we have our trauma center. And even within those categories, we have it broken into little subcategories. Like we have like big rooms, and then we have just kind of like rooms. And so let's just say on the trauma side, the way we have it set up is our trauma rooms 1 and 2. Those, yes, are typically going to be used for kind of like holds and waiting to get sent upstairs to some type of trauma floor. And then we have like our big trauma rooms, which are going to consist of 3, 4, and then 5 is our pediatric trauma room, like OB traumas and pediatric traumas under the age of like 16, 17 go into the pediatric trauma room. And that's where we have like all the pediatric stuff, the Braslow chart, the crash carts dosed for pediatrics and obstetrics. We have a little warmer thing for the neonates. That way, if they come out and we need to resuscitate them, we can do that. Or if they have trauma, we can work the trauma angle that way. And so, like that right there is all in room 5. And then you have 6, 7, 8. 6, 7, and 8 are going to kind of be like holds areas. Again, just waiting to kind of go up to the floor. And then trauma room 9 is going to be like a geriatric trauma room, but it's getting more and more used for different things now too. And then we have 10, 11, and 12. Those are specifically for geriatric traumas. And then 13, 14, those are going to be your mental health people. So they have no trauma whatsoever. They're just looking for attention and probably just hot and hungry or cold and hungry. And then 15, 16, 17, and 18 are also your big trauma rooms. And so this story takes place in trauma room 9, which is traditionally a geriatric trauma room, but it's slowly shifting out of that range. And so, in this particular story, it is not a trauma story. I mean, it is not a geriatric story. It's a fucked up story. So we it's probably 9, 10 o'clock at night, and EMS, HFD, because here in my particular county in the state of Texas, it's Harris County. The fire department doubles up as paramedics before they can even go and put the wet stuff on the hot stuff, right? So, and I think if you like to watch like Chicago Fire or something like that, I believe like maybe more counties are kind of going this way. Because yes, you need your guys putting the water on the fire, but you also have like this need for faster response times when it comes to like 911 calls and stuff like that. And so it just seems to be a better use of taxpayer dollars. I know that firefighters will probably sit there and push back on that, but guess what, dude? Like, there aren't that many fires happening. Uh, so, so HFD, at least in our particular area of town, uh, it can be hit or miss with performance, and so this one was not the best. And when I tell you this story, you're going to be like, how did you miss this? And everyone, like in the trauma bay, thought the exact same thing after the x ray showed. So HFD brings the guy in, AutoPed. And if you're not familiar with ER terminology, AutoPed is auto versus pedestrian. And so the guy was riding his bicycle, and he was crossing the street, and then I guess the guy either ran a stop sign or ran a red light or something, and get ready for it, hit the dude going 30 miles an hour. Okay. He hit the guy going 30 miles an hour. Now, if you get hit in a car doing 30 miles an hour, it's not a big deal. You might get a sore neck. If you really, top heavy, you might have like a severe neck injury. But on the just regular basis, it's just going to be a sore neck, maybe a sore back, nothing crazy going on. Even if you get T-boned at 30 miles an hour, it's not going to be detrimental. It shouldn't be. Uh, but this guy was riding a bicycle and crossing the street, and he got hit doing 30 miles an hour. Now, he got hit and drug. Okay. So he got hit doing 30 miles an hour and then drug 100 feet. Okay. Now, to give you an idea of how far 100 feet is on the road, whenever you're driving down the road and you see the hash line, you see the hash lines in the middle of the road. Each of those hash lines is about 10 feet long. All right. And you're in your car, and it doesn't seem like it, but each of those hash lines in between the road or in between the lanes is about 10 feet long. And so he got drugged 10 of those. Okay. So that's the story. His pressures were stupid soft. Okay. And so when you get hit by a car, I've never been hit by a car before, but I would imagine that if I got hit by a car, um, I would be pretty fucked up. And so this guy his pressures were super soft. And for you guys who are not trauma or ER, or maybe not even wanting to go trauma or ER, or listening to this and thinking if you do, a pelvic fracture is the one of the worst injuries that you can sustain. It is a big bone. It's like a pretzel. So when you think of like a pretzel, like a rolled gold pretzel or something, you can't just break one side of it, right? Like if you're trying to break it down the middle, you can't just break one side of it, because if you do, you'll break another side of it. And the pelvis is exactly the same way. And so when you start twisting it and moving it, like one side's going to break and the other side won't, right? And so one of the worst pelvic fractures is what they call an open book pelvic fracture. And that's when the center of the pelvis is broken and flayed out like a book. Now, the significance of this flayed out like a book kind of picture is that your body is going to dump liters and liters and liters of fluid a minute into this cavity now. And so it is a very, very life-threatening condition, and it will kill you within minutes. Okay. And so like the guy comes in, hit 30 miles an hour, drug 100 feet, and just on the surface, the dermatology is just fucked because he's got gravel and like rocks and stuff embedded into his skin, probably already tattooed. If you are familiar with the term, like usually tattooing doesn't occur until after something's left in the skin and it kind of heals over. Or if it gets embedded deep enough, like it'll like instantly get tattooed. So some of this stuff was already kind of embedded really, really deep. And so me and a nurse, and this is like one of the most beautiful things that I love about, working in like the trauma setting is we work super, super, super well together. Like when we just flow amazingly well. And it's funny because when you look at the political stance of both of us, like we are completely opposite of what we believe politically and probably a lot of other things. But when we come together to work, we work very, very, very well together. And so we're sitting there and we're providing care to this dude, and we get him over to the stretcher, and it got paged out as a level 2. So there was no one in the room but me and her in EMS. And so, and of course, the trauma resident that was in the room. And so we call for the pelvic X-ray because there was no pelvic binder applied. We call for a pelvic X-ray, and when they shoot the X-ray, we see a pelvic fracture that was so wide that you could literally stick a textbook through it. Right, that's how wide it was. And so when we saw that, this is where that anticipatory stuff starts coming into play. Okay. So we see that, and all of us in the room are like, oh, fuck. Like, it wasn't, oh, shit. It was, oh, fuck. Like, this dude, no wonder his pressures are like 60 over 40. And like, he's not able to breathe well. He looks pale, cool, diaphoretic. And this dude was a Black American, and um like like the shit literally just hit the fan as soon as that image came up on the screen, and we knew like we are now running against the clock. So knowing this, what are you anticipating as a nurse, right? Like this is where that annoying shit on these nursing exams comes up. What are you going to anticipate, right? And so like I'm like I look over at the nurse. I'm not gonna say her name. I was like, "Yo, like, like I'm going to probably start these 2 large bore IVs, or do you want me to put a makeshift pelvic binder on?" She said, "I'm going to grab the IVs. I want you to go ahead and place a makeshift pelvic binder on." So I literally just kind of like take the sheet and kind of pull it down from under him, like because we put like a fitted sheet on, and then we put like a white sheet on under them to act as a draw sheet. EMS was still in the room. They didn't bother to help. So thank you, HFD. And, uh, so I take the sheet from the top of the stretcher, pull it down to the waist, and then I take the bottom of the sheet from near his feet, and then I shove it up towards. Now, like a lot of times in EMS, like I'm not a paramedic, so I try not to rag on you guys too much because I don't know like the situation on like when and how the patient was positioned when you put the pelvic binder on, because when we put it on, it's in a controlled environment on a flat stretcher. But you shouldn't put a pelvic binder on by the knees. It's not a knee binder, it's a pelvic binder. So the easiest way for me to think of a pelvic binder is you either want your closure to go around like over top of the genitalia, So if you got a guy, you're going to sit there and you're going to make sure that the securing mechanism is over, his penis and his scrotum area. And then like for the females, it's going to be over the vagina. Like that's kind of like a good landmark to aim for your pelvic binder, the securing mechanism to land. Okay. And so I grabbed the sheet, I kind of like fold it, like all the way down, without moving this guy too much. And like I like tie it over his dick and then I kind of keep moving, right? And like I really cinched it down to where his legs were kind of like flayed out like a rotisserie chicken. Like it was just an unnatural position. And so like when I tied it, I kind of brought them back up to an alignment situation, tied it real quick. Everyone starts pouring in, wanting to know the story. We tell the story when everyone starts coming in and we start repeating the story. Guess what? EMS just kind of floats on out the room, because they knew they fucked up. Because again, who the hell gets hit at 30 miles an hour and drug 100 feet and you don't think that you're going to have some sort of pelvic injury, like because you don't see a broken bone out of his leg that you just think like, oh, it was just a clip and then he was good. No, man, like you fucked up. And so everyone starts coming in and then the trauma attending was like, why was this paged out as a level 2? And he had the same exact thought that everyone in the room had, which was, why was this not paged out as a level 1 when you got hit doing 30 miles an hour? Now, I'm not a physicist by any means, but I'm assuming that if you get hit doing 30 miles an hour, the energy is not at 30 miles an hour. I'm assuming that energy is going to be closer to 60 miles an hour. So I'm not sure, but um, I get the pelvic binder tied on, we secure it, and me and the nurse, like we're sitting there, we're running our stuff. We get blood pressure. Like she's getting another IV. I'm getting a blood pressure on the other arm. The trauma residents calling for a rock and a Tomidate. And they tube the guy and we start MTPing blood immediately. Now, a little side note, like at our hospital right now, we have a little debate going on amongst practitioners, including nursing, is whenever you're MTPing blood, like do you use the J loop or do you just go straight to the IV hub? And the consensus is like all over the place because you have the argument of it's the catheter length that is going to determine how much blood you can push through it. And then you have people that are like, well, it's going to be the J loop, thickness that's going to determine how much blood that you can push through it. Me, I'm at the point where it's like, as long as you get the damn blood in, I don't care how fast it's going. Because we use Belmont massive transfusers, and like you can like deliver like a crazy amount of blood in like a short amount of time. We're talking about like, don't let me lie to you. Like, if I'm not mistaken, it was like 5 liters of fluid in like a few minutes or something like that. If that's how you have it set up, I don't know. Don't let me lie to you. But it's a crazy amount of fluid in a short amount of time. And so, um, but that right there is kind of like an inner debate at our hospital is like, is it the J loop's fault that we can't get any faster, or is it the catheter's fault? And then a good argument is when you look at the IV catheters in their packaging, the longer ultrasound guided, catheters, it'll tell you like it's like um 60, it might be like 60, 80 mLs a minute, for an 18 gauge. And then on the 18 gauges, like on a normal IV, it's like 120, you know, something like that. Don't like it's something crazy like that. Okay. So we start MTPing this dude with blood. We get the blood pressure, his blood pressure on auscultation was like it was still mimicking what the monitor was saying. It was like 60 over 40, 60 over 20, something stupid low. And so like we run it, and then by the time that everyone gets into the room to kind of help us out, me and the nurse uh, or the RN, me and the nurse that were in the room, we had already done everything. So the only thing that needed to be done was rock and accommodate, and then like kind of get the monitor set up. That way we can go to scanner. And the pelvic fracture was so bad that the trauma attending like walks in as we have the monitor and the brain on the monitor ready to go to scanner. He was like, "You guys are going straight to the OR." Shit. Okay. So like if you work in the OR, go to hell. Okay. And that's all I'm going to say about that, because the story kind of continues that mentality. So we got this dude, like he's literally bleeding everywhere at this point. You know, he's not in DIC, but he just has open holes everywhere. And blood's just kind of pouring onto the stretcher, you know, and like we got blood going, we got fluids going, like we're hitting them all different types of liquid stuff to kind of prop up that volume. And so we get up. The ORs for us are like one or two floors up, and we have a special elevator designated for those types of events where we could just hit a button, and it goes straight to the ORs, and that's where we're at. So we get on the elevator, we get to the OR, and they see you guys that work in the OR. You see us walk in with this dude that has all of this stuff, you know, because it's like an entourage of us coming into the OR, and you guys want to sit there and try to hold us up because we don't have a little hat thing on, a little bouffant, and we don't have little booties on, and we're walking into your OR. Like, dude, we are literally keeping this dude alive with, all right, we have literally lactated ringers and blood keeping this dude alive. And you're going to sit there and tell us you need to grab a bouffant? Get the fuck out of my way, dude. So we get in there. The whole OR team is trying to throw a fit, and the surgeon's like, "Yo, we need to get him over, and we need to get going. Quit worrying about what they're wearing. We'll worry about that with some vancomycin." And I'm like, "Thank you, thank you." You know, like you're going to throw antibiotics at this dude anyways. So just throw some more antibiotics at him. Don't worry about what the hell we got going on, because he's laying in rocks and grass. You know, the stretcher has literal rocks and grass on the sheet. So, um, so that right there is the story, right? And the anticipatory stuff of, hey, when you have something like that that shows up, it shows up in whatever you got going on. That's where the nurse anticipates this. I was anticipating two large bore IVs. I was anticipating fluids. I was anticipating blood, and I was anticipating on closing this pelvis long enough for us to get to the OR. Those were the anticipatory things that the doc didn't need to say. Now, that right there is where that stuff comes into play in real life. It's not, you know, a stupid question always. Like the nurse is going to anticipate, you know, ambulating the patient to the bathroom. Like it's not always going to be stupid shit like that. You know, it's going to be, you know, it can be, not going to be, but it can be, hey, you know, you got this patient that got hit by a car going 30 miles an hour and he was drugged 100 feet. What are you anticipating? It's going to be stuff like that, you know? So, I just wanted to hop on and kind of talk about that real quick, you know, because yesterday, like our cohort, we had a really rough not pediatric OB exam. We had a really rough OB exam, and we all kind of like walked out of there mad as hell. Yeah, so um it just brought up like, man, this anticipatory stuff, like I know it's applicable, but the way that they're using it is not real life. So I just wanted to talk about that as a story, and there's like a meaning behind it. So there you go. All right, guys, thank you for listening and keep enjoying the educational material.